Welcome everyone again to the University of New Mexico Law and Mental Health Series, weekly discussions of practice and science featuring experts in behavioral health and the law. This series is run by the Division of Forensic Behavioral Sciences of the University of New Mexico's Department of Psychiatry and Behavioral Sciences in support with the New Mexico Behavioral Health Services Division. I'm Anthony Perillo, the Forensic Psychology Training Director here at the University of New Mexico. For our talk today, if you have any questions for our presenter, make sure you enter them in the Q&A box. You can enter those anytime you feel comfortable. Do know that we hold questions until the end, and oftentimes it's not possible for us to get to all of them directly. If you are pursuing continuing medical education credits, there will be a sign-in sheet posted in the chat box shortly. If you're pursuing APA continuing education credits, the link for that survey will be posted near the end of the presentation, so keep your eye on the chat box near the end of the hour. Make sure that you open that link before you close the webinar, or otherwise copy or bookmark the link. And make sure after you complete the survey that you save your certificate, because we don't have access to copies of certificates after the fact. The recording for this week's talk should be available on our YouTube channel later this week, and PowerPoint slides will be available for those that have registered for the series later in the week as well. I appreciate everybody's support and understanding for the technical issues that caused us to cancel last week's Law and Mental Health talk. As a heads up, that has been rescheduled for next Tuesday. So next Tuesday's talk will be Miguel Nunez and Dre Machette, who will be returning to discuss insights into violence risk assessment from a multidisciplinary treatment team perspective. But coming back to this week, I'm thrilled to introduce you to today's speaker, who will be discussing interplay of ACEs, aggression, and suicidality for those that are involved in the forensic mental health system. This is Dr. Jill Stinson. Dr. Jill Stinson is a licensed psychologist and professor in the Department of Psychology at East Tennessee State University. She holds a dual doctorate in clinical psychology and psychology policy and law. Her research is focused on serious mental illness, personality disorders, self-regulatory problems, and early childhood maltreatment in persons who commit violent and sexual offenses, as well as issues related to community reentry, stigma, and suicidality in justice-involved populations. Dr. Stinson is the chair of the East Tennessee State University Campus IRB, editor-in-chief of one of the premier journals, Sexual Abuse, and has authored 3 books on the etiology and treatment of sexual offending and motivation to engage in therapy. So Dr. Stinson, Jill, on behalf of the University of New Mexico, thank you so much for taking the time out and joining our series, and I'm very excited for you sharing your expertise with us today. I will go ahead and toss it over to you.
Okay, thank you so much for having me. I've been looking forward to this. So before we begin, I don't have any financial conflicts of interest to declare. I will note that I have ridiculously cited myself many, many times in this talk, but you don't have to read any of those papers. But no financial conflicts of interest, and the views expressed herein are my own and do not represent the views, policies, or positions of the University of New Mexico, who is graciously hosting this webinar today. All right, so thank you for that introduction. As Dr. Perillo stated, I am Jill Stinson. I am faculty here at East Tennessee State University in the Appalachian Mountains of Northeast Tennessee. And prior to coming here, I worked at Fulton State Hospital in Missouri, which is at the time, it was a 500-bed intermediate maximum security forensic psychiatric hospital. It's changed in size somewhat since then, and they've built a shiny new building that I never got to work in. But my history and my grounding is in the forensic mental health system. And because I know we have a really diverse audience today, I'm just going to use some terms and I'll define them as we go. But broadly, as we talk about the different systems, mine of forensic mental health is where these are folks who have serious mental illness, who have engaged in some kind of aggressive or criminal behavior, come into contact with the legal system, and are receiving secure psychiatric care, as opposed to people who are in the correctional system, who are in a jail or prison, or on probation or community supervision, and also as opposed to people who are psychiatric inpatients but who have not become hospitalized due to violent or aggressive behavior. So I'm going to focus my talk today on that population. And we're going to talk about adverse childhood experiences in this population. We are also going to talk about the pathway between adverse childhood experiences and other behaviors of concern in forensic mental health system consumers. Things like aggression, suicide, and self-harm, criminal behavior. And then we'll also talk about trauma-informed care practices and future directions so that we can better serve this population as they receive help. All right, so just starting off here, when we talk about adverse childhood experiences, many of you may be familiar with this term or this body of research. The original ACE survey was conducted by an insurance company, Kaiser Permanente, in Southern California, where researchers were interested in predictors of adult health, and so they were interested in knowing more about the experiences of their patients and ways that they could better or more accurately predict adult health outcomes. And to some extent, the results surprised them because what they found is that some of the strongest predictors of adult health, including both mental and physical health, were things that happened to people in childhood. And collectively, they identified 10 categories here of childhood abuse, neglect, and household dysfunction that were important predictors, but also cumulative predictors of adult health risk. And so these are depicted here in this image, but we have a range, including different forms of neglect, different forms of abuse, and then evidence that there was chaotic or dysfunctional upbringing in their home of origin. Some of these, they're not equivalent, right? We see parental separation or divorce, and we also see sexual abuse. Like those experiences are not equivalent. But what they discovered as they conducted this initial research is that these were important predictors of a wide range of outcomes, and that also as they increased for an individual, the severity of their health risks increased as well. So this kicked off, 25 additional years of research looking at cumulative and overlapping forms of risk. Prior to that, most of the research had really just looked at these as singular events. And so what is the effect of physical abuse? What is the effect of having an incarcerated family member? And here they're looking at it cumulatively. And they identified important moderators of this process as well, so that we know that when people experience these ACEs, especially in this cumulative graded fashion, it leads them to adopt sort of behavioral risks, things like drinking, smoking, overeating, that then can lead to negative health outcomes in adulthood. So since then, much of the research and a lot of my research has been looking at additional forms of ACEs and additional qualities of those ACEs, because on the original ACE survey, it was just these 10 items. You have a graded score of 0 to 10, right? And they're not all the same. And each person's experience of these may be different. Ongoing forms of abuse, depending on also who the abuser was, how the systems around this individual responded to the abuse, those are all important factors as well. But from my perspective, and the reason I was really interested in this initially is, we see differential risks across different populations and settings. And within forensic mental health, we're consuming this literature on ACEs, and most of it says once someone has a score of 4 or higher, these outcomes get substantially worse. And my colleagues and I at the hospital used to comment to each other like, all of our people have a score of 4 or higher. There has to be something further that gives us information and tells us what we need to know about how to prevent negative health outcomes in our folks. So we do know that people in forensic mental health systems, they reside at this intersection between people with legal system involvement and people with histories of serious mental illness. And so initially, a lot of the information we were getting around ACEs was coming from these two different sources, and we can extrapolate information about forensic mental health system consumers from those sources. We know that in people with legal system involvement, that the rates of abuse and neglect vary widely depending on the sample, often with incarcerated, more serious and violent offense related samples showing much higher rates of abuse and neglect than those who are under community supervision or misdemeanor offenses. But we know that that's true for adults, that many adults report prior instances of childhood adversity. And this is also especially true as well for youth. And so we know that justice involved youth have fairly high rates of ACEs, and they haven't reached that age at which ACEs are done, right? Because ACEs are measured up until the age of 18. So we know that people with legal system involvement have high rates of ACEs. We know that that metric of ACE score of 4 or higher, that 30 to or almost 50% of adults who have legal system involvement, and half to 2/3 of youth with legal system involvement evidence, an ACE score of 4 or higher. And these stats are all among males, which will become relevant later as we talk about the differential experiences of ACEs between men and women. Then we turn to, okay, we have our forensic mental health system consumers. They are people with legal involvement, but they are also people with histories of serious mental illness. And so we see similarly high rates of ACEs in this population as well. And this is a whole range of people who have psychotic spectrum disorders, bipolar disorders. I like to talk about serious mental illness in the terms of if it meets a standard where the person cannot perform everyday functional tasks. So it could even be really extreme depression and chronic depression in folks where it interferes with their ability to work and maintain relationships. Then that, I would count that as serious mental illness as well. Also, sometimes in that category, we see some of the personality disorders. But within this population, we also see really high rates of ACEs. We see that early trauma and childhood adversity has been linked with simply having a diagnosis of serious mental illness in adulthood. So we know that it's a risk there. It affects the onset of mental health problems and the severity of psychiatric symptoms. So from this, we know that this population in the forensic mental health system is likely to experience high rates of ACEs simply based on these shared characteristics. So forensic mental health system consumers broadly are people who have serious and persistent mental illness, and along with that comes a pretty lengthy history of institutionalization, polypharmacy, or the use of multiple medications to control their mental health, but also physical and chronic illness comorbidity in people with serious mental illness. In fact, in the facility in which I used to work, one of the single most expensive line items was medication for diabetes and high blood pressure. We were in a maximum security psychiatric facility, and very many people were on psychotropic meds, but it was the medications for chronic medical conditions that were the largest part of the pharmacy budget. We see a lot of functional and relational impairments that may be disrupted by symptoms of mental illness, but also periods of hospitalization that can disrupt a person's vocational activities, their relationships, their social support, their education, etc. And so we also see this population, obviously they have legal system involvement because they are part of the forensic mental health system. So we have business that we have to think about with this group. And also they come to us with a lot of trauma and adverse life experiences. As we talk here in a minute about ACEs, that's childhood, but they also continue to experience many of these things in adulthood as well. And I'll go into that a little bit more. But these are folks who come to us having had a lot of really negative life experiences. And that does impact their overall functioning and their wellness and well-being. There are also folks who have experienced a lot of marginalization and stigma. Because if we think about it, they have multiple potential stigmatizing identities that they come to us with. They come to us with serious mental illness, which, a lot of stigmatized beliefs exist about the treatability of serious mental illness, the safety of people with serious mental illness. associated with their justice system involvement. And so when they have legal involvement, all of those come into play as well. And then they may hold other identities that further stigmatize them, including being a victim of childhood abuse or neglect. So what do ACEs look like as we have this group with, legal involvement, serious mental illness? We know that rates of ACEs are elevated in samples from forensic mental health systems. Most of our research in this area comes from the US, Canada, UK, and Germany primarily. I often joke with my colleagues that there aren't very many of us who study this, honestly. But we do see lots of overlapping things across different samples from different geographic locations. We know that they experience very high rates of ACEs, such that, 2/3 to nearly all have experienced at least one known adverse childhood event. A very great many of them have scores of 4 or higher. And there's variability here because it depends on the security level of the sample you're looking at. It depends on the gender of the sample that you're looking at. And we see differential experiences by different types of ACEs, with some being much more frequent and common than others. But there's still a lot we don't know, for example, about the true rates of ACEs in this population. As a way of illustrating that, for example, one of the least often noted ones is emotional abuse or emotional neglect. And when you talk to people about their experiences of that, they've very clearly experienced it, but they won't report it when they're an adult. And they say, well, all of these other things that were going on in my home. I can think of one client, for example, who was being sexually abused by multiple members of his family. He was being physically abused by a stepfather. His mother had untreated bipolar disorder. His mother also abused substances, and there was lots of just general chaos. He had many, many foster care placements throughout his life and lots of psychiatric hospitalizations early on. And so his view of it was that was kind of just not worth mentioning. There was so much else that was so much more severe that he just didn't see the need to report that he was being emotionally abused and neglected as well. So there are some categories that we just don't really know as much about when you get to this population that has such an aggregation of adversity. We also know that ACEs are more prevalent among women in forensic mental health systems, where I have some stats for you here, but they have very, very high rates of ACEs and very severe ACEs and often ongoing ACEs. So it won't just be an incident of sexual abuse, but multiple and by multiple perpetrators over time. And so when we see women in these systems and they only comprise about 15 to 20% of a lot of forensic mental health hospitals, these are some of your folks with the greatest aggregation of early trauma. We also see other things, though, that aren't always well accounted for in just this ACE survey metric. Things like out-of-home placements and early psychiatric hospitalizations, which are also disruptive to development, and may carry with them their own experiences of abuse and neglect, because sometimes they may be in placements with other youth who are aggressive or violent, or in hospitals where people may not be stable and may engage in a lot of aggressive behavior. And then we see that people have continued experiences of trauma and maltreatment in adulthood as well, and oftentimes as part of our systems. So they may be in a facility with other people who are aggressive. They may be victims. They may witness things in these facilities. We also know that because of those stigmas and how people view certain types of legal behaviors, if they've engaged in any kind of crime against a child, or if they've engaged in sexual crimes, they may be targets by other consumers within the same system. And so they tend to continue to experience this. In one recent sample, for example, 2/3 of them reported both childhood and adult traumas that had occurred. So just to give you a sense of this is from one of my samples. I picked it because I know this group very well. So this can just illustrate this a little bit further, this gender difference and how this looks across different forms of ACEs. You can see here with the lighter purple bars being women and the darker purple bars being men. That in this particular sample of just under 200 people who resided in intermediate and maximum security, these are their reported rates of ACEs taken from their records, which included, social service history interviews, psychological evaluations, medical evaluations, court records, things like that. Um, you can see that women reported more experiences of these than did men, which could also be biased in that men are less likely to report than women are. But also you notice here as you look at these percentages that these are folks who've experienced more than one, right? They've often experienced these overlapping or cumulative ACEs. And so here in this same sample, the average ACE score in women was nearly 4 with a mode of 7. That's pretty strikingly bad. And among men, it was just over 2, but that's still quite high. Nearly 2/3 of women and a quarter of men had a score of 4 or higher. And in addition to these 10 reported ACEs, we see other types of experiences they've had where many of them reported that in their home of origin, there was an investigation for child abuse or neglect, whether it was them or a sibling. And nearly a quarter of them had been placed in foster care at some point prior to the age of 18, with an average age of placement at around 8 years of age. A fair number of them had been placed in foster care before the age of 2. So, these are folks who, if we take that out of home placement as a proxy indicator of severity of ACEs, it was severe enough that they were removed from their parents' care. And their average number of out of home placements was 2. And so if we think about the level of disruption that can occur for a child when they're removed from their home, whether it be into foster care or a group home or a psychiatric hospitalization, this is a fairly high number. So when we think about the implications of increased ACEs, obviously most of the research has honed in on problems with physical and mental health, substance misuse and dependency, and then relationship difficulties and mistrust. But also when we start looking at forensic mental health consumers, we're also talking about aggression and sexual behavior problems being a concern and being linked with ACEs, as well as suicidality and self-harm. So let's take a look at that. What do we see? So in terms of psychiatric symptoms and prognosis of illness, we see that a higher number of ACEs is associated with the early onset of serious mental illness in forensic mental health system consumers. The number of diagnoses they receive or the number of diagnostic categories, so they may have diagnoses reflective of psychotic symptoms, mood symptoms, personality, psychopathology, the age at their first hospitalization, and the increased use of psychotropic medications. And we'll talk about it in a minute, but psychotropic polypharmacy in particular. In terms of suicidality and self-harm, for these consumers, we know that ACEs are linked with a greater likelihood of having a history of suicide attempts and a history of self-harm. And also, in terms of specific experiences of ACEs, in one of my samples, we found that sexual abuse was related to the first psychiatric hospitalization being preceded by a suicide attempt or prompted by a suicide attempt. So we have this path between sexual abuse, suicidality, and then psychiatric hospitalization that was significant, particularly among women, more so than men. But we also see that ACEs have implications here for the onset and severity of aggression and criminal behavior. So earlier onset of aggression, earlier age at first arrest, number of criminal charges. ACEs are also associated with a greater likelihood of charges related to sexual and violent offending, and then also aggression while residing in an inpatient facility. So here we see that increased ACEs do have these implications for forensic mental health system consumers and the types of risks and behaviors that merit treatment as well. So when we dig into this a little deeper, sorry, my voice is starting to go out. We dig in this a little deeper, we see that there are some considerations for psychiatric symptoms, prognosis, and hospitalization that are relevant for prevention and intervention and risk management in these particular consumers. So, found that those in foster care were nearly 16 times more likely to be hospitalized before the age of 12. And so, there may be some of you out there who work in forensic mental health for children and youth, and you know, kiddos who are hospitalized really early on come in with a lot of extreme adversity and things that have happened to them that dramatically increase their psychiatric symptoms and their risk of future hospitalizations as well. Because what we see is not only are ACEs and the severity of ACEs that merit removal from a home of origin, such that they have an increased likelihood of early hospitalization, but it's usually frequent and ongoing episodes of hospitalization throughout their lives. An interesting finding that we noted in one of our samples was that the ACE score, among other things, helped determine whether a person's first contact with the system led to hospitalization or arrest. And so here, a higher ACE score was actually associated with psychiatric hospitalization rather than arrest. So if you can imagine the scenario, maybe a child has been acting out or a youth has been acting out, and the police are called and they come and they have to make a decision about, does this person get taken to a hospital for evaluation and care, or do they get taken to detention? And in this study, we found that the higher the ACE score, the more likely they were to be hospitalized. And we, just based on our knowledge of this particular group, and also based on some of the literature, hypothesized that these are probably folks who were known to authorities already, that their families were known to authorities, and it was known that they maybe had been removed from the home previously, or that they had ACEs going on in their homes. And so it was just assumed that they were experiencing a psychiatric episode more so than what we would see as kind of aggressive or criminal behavior. We also see among this population the underdiagnosis of PTSD, and this is an interesting one, and I'll talk more about it in a bit when we talk about future directions. But McKenna and others have noted that a comparatively small number of people in the forensic mental health system are diagnosed with PTSD, despite the level of ACEs that I've just previously shown you. And obviously, not everybody who experiences trauma is going to develop a diagnosis of PTSD, but there are some particular complications with this population that we may be vastly underdiagnosing trauma-related responding. And then also, as a result, probably not providing treatment for some of the trauma that people have experienced. And then finally, to increased use of seclusion and restraint. And so in these facilities, when people are aggressive or engaging in some kind of unsafe behavior, they have an increased use of seclusion and restraint. And we find that that is significantly also predicted by their ACE score. All right. Now, this is a study that was conducted by one of my students, actually, and it was really interesting. She was wanting to understand more prescription patterns in forensic mental health systems. And in this study, we found that an increased ACE score led to an increased prescription of psychotropic medicines, and in particular, antipsychotic medication. And so people are using medication to control behavior that may be partially predicted or driven by trauma. And so, the idea being that we get our prescription practices because many of these medications have some pretty severe side effects. They may be counterindicated sometimes with one another. And on average, we know that people with higher ACE scores die earlier, and we know that people who are on um, many psychotropic medications, and when I say many, I'm like 4 or more psychotropic medications, that also can decrease their lifespan as well due to side effects and other associated things. So we want to be careful with that. Um, we know that people too who engage in self-harm and aggression within forensic mental health system care are more likely to experience psychotropic polypharmacy, sometimes in order to control those behaviors. And so just kind of have an awareness that this has implications for more than just behavior and then the types of therapy people need, but we also are looking at psychotropic treatments as well that are impacted by an ACE score. Okay, so moving on to self-harm and suicidality and the association with ACEs, we know, for example, that suicidality is much higher in people with legal system involvement, more so for women than men. But it's much, much higher than we would see in people without justice system involvement. In a forensic mental health sample described here, each additional ACE increased the odds of a suicide attempt by 123%. So we know that ACEs have this direct link in forensic mental health consumers with suicidality. We also know self-harm is a risk factor for suicide among people with serious mental illness, and that there are specific psychiatric diagnoses that are associated with increased suicide and self-harm behavior. Obviously, we tend to think of that in the way of depression and PTSD and borderline personality disorder. But we also know that having a psychotic spectrum diagnosis, whether it's, schizoaffective disorder that has a mood component or schizophrenia, those folks are at much higher risk of suicide and self-harm as well. And people with antisocial personality disorder are at increased risk for suicide and self-harm. We know that the recency of their hospitalization or recency of trial are important risk factors for forensic mental health system consumers. This is similar in incarcerated populations as well, but here with the addition of serious mental health concerns, you have an exaggerated risk above and beyond what people with legal system involvement and no serious mental illness would experience. And we know that there's a lot of overlap between suicidality, which includes suicidal ideation and suicide attempts, and self-harm, in that one of my samples, 2/3 of them had engaged in both suicide attempts and self-harming behaviors. And so responding to those behaviors as a system, people respond to self-harm sometimes differently than they do to suicidality because the level of intent is different, or the form of intent is different, and the level of lethality may be different, but these are folks who've engaged in both quite frequently. And then in terms of aggression and criminal behavior, we have a lot of overlapping correlates between aggressive behavior and trauma-based responding, right? So we see increased impulsivity, increased self-regulatory deficits, or that ability to regulate emotions and behaviors, and then also increased substance misuse. So some of the same risk factors for aggression are things that we see kind of categorized as potential trauma-based responding in an individual. And we also know that there are systemic responses to aggression and criminal behavior that are probably not the most trauma responsive, let's just say. And so this idea of hospitalization versus arrest and what happens to people when something occurs, and do people around them recognize serious mental health concerns right away? How do they treat someone based on whether or not they know there is a trauma history? And then if we think about how our systems are structured and the way that we develop rules in forensic mental health systems, many of these are not trauma informed or responsive to people's trauma related needs, and may in fact exacerbate symptoms or exacerbate experiences of continued and ongoing trauma. So we've built our systems in ways that are intended to be punitive. And even though within the forensic mental health system, there is a um, much greater acknowledgement of the need for treatment and intervention, they still are secure facilities. And so there are rules in place and restrictions in place that can, again, make people feel unsafe. And if these are people who've experienced a great amount of interpersonal trauma, that can exacerbate their trauma responding. So, in thinking through the mechanisms here, when we pull back and look at the broader picture, um, we see that oftentimes people within these systems have a lot of early vulnerabilities due to biological development or genetics. Some of my research has also looked at diagnoses of serious mental illness in people's parents and the implications that that may have had, genetically and biologically for this individual, for early onset of their symptoms, for management of their symptoms, et cetera. But we see these early vulnerabilities. We also see these ACEs and then continued experiences of maltreatment and adversity as they reach adulthood. This contributes to patterns of dysregulation or inability to kind of regulate one's emotions and thoughts and behaviors and interpersonal relationships, and the addition of trauma-related responding and what that does in terms of the person's ability to manage their experiences and their responses into things that are going on around them. And they can learn and have reinforced some really maladaptive strategies for coping with that dysregulation. So, we see that people engage in substance use, alcohol use. I often, when I do trainings in how to kind of conceptualize these behaviors, I say, oh, sometimes aggression is a maladaptive strategy. If someone is threatening or harming you and you harm them back, they may stop. That's what these clients may have learned. They may have learned that the best way to handle anger is to be aggressive because it's been modeled for them in their environment. And so we see that these strategies get reinforced over time, and they, in some of these clients, will manifest themselves in terms of a range of problematic behaviors, including violent and sexual offending, including suicidality and self-harm. And so, we really want to understand here how this long-term view of what has happened to someone very early on and how it has progressed over time to lead to what they're experiencing today. So, some of the challenges here that we face are recognizing and addressing trauma, both early on and in our forensic mental health systems once people have reached them. Understanding the continued impact of trauma on behavior and relationships and learning to conceptualize these as trauma-related responses. Um, I've done a lot of work in this area, obviously, and I remember interactions with clients where they would say, well, if I get really aggressive, they put me in seclusion and then everyone leaves me alone. And if they got fearful on their ward or felt like they were going to be out of control, this idea that if I can get myself to a safe place, even though we don't often think of seclusion as a safe place, but they would say, I'm locked in a room by myself and no one can get to me except staff. Um, so this idea that we want to better understand how trauma is feeding into those patterns and feeding into those relationships. Another struggle with this is that self-regulation and trauma responding are inherently idiosyncratic to the person. And so we really like to have standardized everything, right? Standardized assessment, standardized manuals. I'm a fan of those. But it is challenging when you're looking at something that is so individualized. How do we treat it? How do we assess it? How do we intervene when it requires a lot of nuance and clinical sophistication in our treatment planning, because it can't be a one size fits all approach. It can't be just one group that everybody gets, right? Um, we also see as a challenge the interconnectedness of different treatment needs that people are presenting with, because I've just presented you all this data with okay, there's a lot of trauma. There's a lot of really serious and overlapping and continuing trauma. And there's suicidality and self-harm and aggression. And by the way, really serious symptoms of mental illness that also need treatment. So when you're looking at this really complex picture, it may not lend itself well to this nice sequential focus in treatment, where first I fix this and then I fix this and then I do this. Because people have competing needs that may, again, they're very idiosyncratic and they go back and forth. Um, we also see this diverse range of self-regulatory problems and maladaptive strategies that people have developed. And so targeting our interventions appropriately can be really complex. And then a final challenge, and it's not really the final, there's many more, but another one is just the length of time needed to see improvement can sometimes feel discouraging or defeating for these folks and also for those working with them, because again, you have this, interlocking set of challenges and you're trying to address many things at once and many things that have been established patterns of behavior for a very long time. And so it may be very slow to see progress. And that can feel sometimes as if you're not getting anywhere, both for us and for the consumers. All right, so some best practices to highlight here. We have trauma-informed care approaches. Trauma-informed care is a phrase that many people have probably heard. It gets used a lot in a lot of different systems and agencies. But we do know that trauma-informed care approaches have made their way into forensic mental health systems. Um, it's it's this idea that we have to assume that these ACEs and ongoing experiences of trauma have a continued lasting impact on a person's behavior and their well-being long after the trauma has occurred. And so, we may have, I remember I mentioned that in one of the samples that I was citing for my own research, that um, the average age at first foster care placement was 8 and the mode was 2 and under. And if you have people who were placed that early, they don't necessarily remember what it was that led to their placement, but that doesn't mean it doesn't have an effect on them much further into the future. An effect on their fear, an effect on their trust, an effect on just feeling safe in their own environment or safe around other people. And so the key principles here of trauma-informed care, we have safety, trust, collaboration, empowerment, choice, and cultural humility. There's a lot of really great work and like toolkits out of SAMHSA, the Substance Abuse and Mental Health uh, Services Administration here in the US. And so there's a lot on how to integrate this into various systems, but I think it lends itself well to forensic mental health when we're looking at people who've had legal system involvement, people who struggle with their mental health. And, how do we build systems that are responsive to the trauma that these folks have experienced in their lives? Incorporating trauma-informed care principles into treatment requires, again, a highly individualized approach. And, that is challenging in a system that likes to just sort of roll out an intervention and it fits for everybody and we can standardize it. And so then we know that it's following certain rules, but in some sense, you have to individualize these in order for them to be most effective. And that is very resource heavy and time consuming in terms of staff engagement and involvement. And we also, in order to do this, we have to prioritize client engagement because this is not something that we can just throw at them and they receive it and they're fine, right? They have to be engaged in the process and it has to be a collaborative process in order for it to be successful. In forensic systems, we have this added consideration of autonomy, collaboration, safety, empowerment. These are things that may not be as readily acknowledged in forensic mental health systems. These are folks with legal involvement, so we remove some of their autonomy. They can't choose where they live. They can't choose who their providers are. They have to follow our rules. Um, They may not feel safe in those environments. People may not collaborate with them as readily on what their needs are. They kind of come in and say, this is what you need, here's what you have to do. And they remove some of that choice that is so fundamental to trauma-informed care. And then another best practice to note in a meta-analysis that Teresa Gannon and her colleagues conducted, they found that the treatment effectiveness in these forensic systems is largely predicated on the qualification, training, and supervision of treatment providers. So we have to really think through who it is that's providing the treatment, how they're trained. I mean, we would think this goes without saying that you have to have people who are qualified and trained, but forensic mental health systems are experiencing a lot of staffing crises, both during and after the pandemic. And so they're losing staff, they're losing experienced staff. And it's very, very challenging to ensure the quality sometimes of the treatment if the staffing concerns outweigh the ability to provide the treatment in the way it is intended or in the way that it's needed. Okay, checking my time here. I think we're good. So, in terms of future directions, I mentioned this with regard to PTSD. The way that we diagnose PTSD, if we're using the DSM in particular, doesn't always allow for these really complex PTSD diagnoses. They expect a trauma to have been kind of a singular event, um, and they don't necessarily account for that cumulative ongoing nature of a potential threat. You can work around that to an extent, but the first category is, identified trauma. And when somebody has so many things and household dysfunction, for example, being identified as one, it may not be readily seen as a traumatic event, but the person is experiencing it in that way. And so we don't see as much about how do we diagnose PTSD in these folks with these cumulative overlapping experiences of adversity. There's been some work done suggesting that we need to do better at looking at the person's own offense or own violent behavior as a traumatic event for them as well. Um, you know, I know from having worked with this population that oftentimes they're traumatized by what they did because especially for my clients who were not guilty by reason of insanity and who, you know, in their view, it wasn't really me that did this. They know it was them that did this, but not the them that's sitting in front of you now, right? And they say, like, I'm horrified that I did that to another person. And so they experience that as a trauma as well. And if we think about how these systems are structured, we make them recount it over and over again in many cases. And so we haven't really looked at how do we categorize that as well. And some research has found that it may be they may underreport PTSD quite often when the primary diagnosis is a psychotic spectrum disorder. There's some suggestion that early on, people may dismiss things like flashbacks as hallucinations, or that when they report trauma-based experiences, people may believe it's delusional or may think their fixation on it is delusional, when in fact it is PTSD. And so that's an area where I think the systems and the people that work in these systems can get a lot more focused at how do we recognize and diagnose trauma-related responding in this population, because in many samples, including my own, if you look at diagnoses of PTSD, it's often around 10%, but we're seeing this aggregation of childhood, adolescent, and adulthood trauma that would suggest that there's a higher prevalence of PTSD. I mentioned this somewhat earlier, but further considerations given to caregiver mental health and suicidality. Because in some of the original ACE survey work, they found they would have these samples of tens of thousands of people, and They wouldn't have anybody who had a caregiver who died by suicide prior to that individual, that participant turning 18. But in working with forensic mental health system samples, we find multiple people within smaller samples, several hundred people, who had a parent die by suicide when that consumer was a child. And so we see this greater aggregation of trauma, but some of these more extreme things. We also know that when you're looking at considerations of caregiver mental health and suicidality, we also have genetic contributors and experiential contributors that we don't fully understand yet in terms of how that is driving suicidality and psychiatric symptom presentation in this individual in adulthood. Um, we know some of the risk factors for these things, but the mechanisms are quite complicated, especially when you're adding into the mix all these experiences of ACEs as well. And then thinking through, I mean, this is kind of my line of research, right? Understanding ACEs and outcomes in really high risk populations. If you have people with a disproportionate exposure to early childhood adversity, ongoing adversity, overlapping and continuing experiences, what is different for them? How do we intervene earlier? How do we identify protective factors and experiences that these individuals may have also had? And so we focus a lot on risks and deficits and ACEs and things that have happened that are negative, but what are the positive supports that they've had that may serve as protective factors? What does resilience look like in this population? That we're not as clear on yet. And so that's a clear area for additional development. And then for these trauma-informed approaches, just what works best and with whom. Um, I think, again, like I said, trauma-informed care is a phrase that many people are familiar with, but what does it actually mean? And how do we make that work within systems that may not be built or designed to be trauma informed? Systems that may have been built to be punitive, or systems that were built to protect the public while also providing treatment. So how do we help our systems adjust in a way that is beneficial for these clients in particular? And then how do we make policy changes related to a whole range of things, right? Like intervention, risk and risk management, community monitoring and supervision, policy changes related to how mental health systems are structured and funded that would allow for us to do this more nuanced, individualized work that may be necessary for this population to thrive. All right. So with that, thank you. I'll leave this up for a second with my email address here, but then I'll click over to the QR code. And Anthony, I believe you're going to kind of pull together some questions for me in our remaining few minutes.
Certainly, I will. Yes, thank you. Thank you so much, Dr. Stinson, Jill, on that thorough and very helpful overview there. The QR code is up that will help you access the survey for APA continuing education credits. The chat box should very shortly include a link that has the survey as well for APA continuing education credits. In the meantime, if you have any additional questions for Dr. Stinson, feel free to enter those into the Q&A box while we're still on. Someone asked if you know why rates of suicidality might be higher for women who are involved in the legal system.
Yeah, it's a complicated answer. I sort of don't know, right? But I have some thoughts. So, one thing, having worked in these systems, for those of you who couldn't pick up on it while I'm talking, I am a behaviorist. I do DBT. You probably heard things through a very behavioral lens. But I worked on our DBT wards, which included men and women, but quite a few women. And so I think there is something about the women who are in forensic mental health systems that may lend itself to a higher prevalence of suicidality and self-harm. Many of them are coming in with diagnoses of borderline personality disorder or something that is BPD adjacent. We used to say when we got people with like personality disorder, NOS, mood disorder, NOS, intermittent explosive disorder, history of self-harm, we're like, oh, I think we know what that is, right? And so though we did have women within those systems who were primarily there for psychotic spectrum disorders and didn't have as much of that sort of dysregulated behavior and affect, I think there's a higher concentration of borderline personality disorder among women who are in these systems, which probably also contributes to it, inflates the degree to which they have suicidality and self-harm. I also see that I don't know how to describe this well, but in both corrections and forensic mental health, you have such a smaller proportion of women, where it's usually 15 to 20%, and those are your more impaired people, right? And so when you have this wide array of men, you're going to have greater variability in the level of sort of functionality and psychiatric stability. But when you concentrate some of your essentially most aggressive and most mentally ill people in a small group in one facility, you're gonna see a higher degree of aggression and self-harm and suicidality because those are simply the people who are sort of suffering the most. Um, because when you start looking at samples of men that are sort of your highest risk, most concentrated, their rates of suicidality and self-harm then approximate those of women. So if you think about it, there's kind of different trajectories for people in forensic mental health, and women tend to be on that higher acuity trajectory for lots of things, including suicide and self-harm.
Wonderful. Thank you for that. Somebody wanted to inquire if there are any statistics kept on children that are voluntarily placed into foster care or residential treatment by their parents regarding ACEs or future contact with the criminal justice system.
Yeah, I don't I know there is literature out there, particularly child welfare system literature looking at that. Those, from my limited recollection, those folks tend to have, they may still have quite high rates of ACEs, but they have more stability over time because there isn't, um, I guess to put it very colloquially, a fight with the system. Most of the clients with whom I had worked in forensic mental health, they were removed from the home against their parents' wishes, right, by child welfare. And so there was this back and forth of parents trying to get them back and then them being removed again. And so for what I've seen on placement literature, the voluntary placements tend to have more stability, which probably plays out differently for that child or youth over time.
Wonderful. Somebody noted of some of the 10 factors regarding ACEs that you listed earlier in the talk that most of them appeared to be focused on parent behavior. With that in mind, are there any recommendations for as it relates to parent behavior toward children?
Um, yeah, if we could go back and fix their parents, right? Um, I Ironically, I met quite a number of my clients' parents, and many of them had very similar mental health needs that were untreated. We know there's a large literature out there looking at intergenerational trauma, and I feel like kind of the earlier you can intervene, I always hold the idea that people don't set out to harm their children, right? We would hope that they're wanting better, but maybe don't know how. And so I think um, more parenting interventions, more recognition of just people who are under-resourced and need help. Um, yeah, I mean, I think more broadly being able to intervene before it reaches a point where the solution is just remove the kid from the home. Um, but yeah, I don't do as much work on that side. I have colleagues who do a lot of early parenting interventions, and I know a huge focus is on kind of breaking those cycles of intergenerational harm and intergenerational trauma.
We have a couple of people asking about the sort of the flip side to this. I'll do this last question here with the it's because they said maybe this is a completely separate talk at this point. Preface it with saying awesome talk. Could you please speak to methods for exploring protective factors? This seems like an important counterpoint to ACEs.
Yeah, I wish that's one that I'm trying to learn more about myself. I feel like so much of the initial literature on protective factors is just absence of risk, and we know that that's not it, right? We know that there's more there. Um, I think it's in its infancy, honestly, in terms of, in my view. I think we have a sense of protective factors for other sorts of behaviors, but when we have these just overlapping things that we're trying to address, like what are the protective factors related to mental health prognosis and protective factors in dealing with trauma and adversity, um, you know, the earliest ones that have come out are things like social support, and that becomes tricky when we look at the fact that the majority of people, their social support is their families. And if we look back to the ACEs, as someone noted, these are all things their parents are doing or their caregivers are doing, and so some of those things that we naturally gravitate toward in the protective, positive resiliency literature, it's like we may have to start somewhere else, or there may be some work to do with those support systems to help them be healthy and protective of this individual. So.
Great. Well, we are at the top of the hour. I'll read one final comment to you here for additional context. Thank you for this presentation. In my work with police officers who have disproportionate histories of adverse childhood experiences, the law enforcement population could easily be substituted for forensic mental health corrections population in terms of negative outcomes. This work is likely best approached using a syndemics framework to address interactive effects. To be continued. Thank you, Dr. Stinson. Just to highlight the additional implications or extents that people have seen benefit from this. So thank you so much for sharing all of your work and all the work in this area on this. I know that people have found this extremely helpful and appreciated your email out there if they had any additional questions. So that wraps up this week's Law and Mental Health series. As a reminder, next week we will have Miguel Nunez and Dre Machette who will be returning to discuss insights into violence risk assessment from a multidisciplinary treatment team perspective. We hope to see you then for another great discussion of issues in behavioral health and the law. Until next time.